Hello, friends. So, giving a brief overview on this very broad topic, acute decompensated heart failure. So, as you would understand, this is a very big topic. You could possibly have a one-day whole CME on this. So, I was asked to give a talk on this in BRIC meeting that happened in Bangalore on 8th November 2024. So I'll try to give a brief sort of an overview on how we approach this, clearly understanding it's a very huge topic. So let's look into how do we define decompensated heart failure. So the definition should encompass three important components. The patient has to be very symptomatic. He should be fatigue, he or she should have fatigue, short of breath, or nocturnal dyspnea, or orthopnea, paroxysmal, any of these symptoms. So patient has to be symptomatic. And the second component, which is important in calling someone as decompensated, is the heart function has to be abnormal. So there can be systolic dysfunction, diastolic dysfunction, and generally all these are associated with increase in the LV filling pressure. So there has to be increased filling pressure in the ventricle, suggesting there is lot of fluid congestion or pulmonary edema in conjunction with diastolic dysfunction or systolic dysfunction, or it can be right heart failure, or it can be with heart failure with preserved ejection fraction, so which we'll talk about. So there should be abnormal cardiac function that should be prevailing, and they should have a lot of features of systemic edema. So it could be pedal edema, ascites, or raised JVP, so on and so forth. So these three are the important constituents of defining that patient has decompensated and has become symptomatic with increase in the fluid component within the body. It can and systemic presence of fluid and in the lung fluid with cardiac dysfunction. So the onset and severity of any of these decompensated heart failure is dependent on the underlying cardiac disease. And that underlying cardiac disease could be coronary artery disease, it could be valvular disease, or it could be cardiomyopathy, which we'll talk about. So the underlying disease, there should be the severity of the underlying disease determines the severity of decompensation and the rate of progression of the underlying disease. So the onset and severity is dependent on these two factors, the underlying cardiac disease and the rate of progression of the disease. So when you look at epidemiology of acute decompensated heart failure, so it occurs in a very heterogeneous population, and it is cited as one of the commonest cause of readmissions into the hospitals. So post discharge of these patients, the commonest cause of readmission to hospitals is touted to be acute decompensated heart failure. And the evidence from across the nations has shown that it is the leading cause of admission in patients, in elderly patients, and up to 1 million per year admissions happen from the data from US and Europe. And I'm sure in India also the data would be very similar. And increasingly, we are seeing in our IC also increasing presentation of patients coming with heart failure, which very often would be treated as LRTI. But very often you evaluate these patients, they would be having concomitant presence of heart failure symptoms, and there'll be a lot of fluid component, and not necessarily always this will be associated with reduced cardiac function. It can be with normal cardiac function, where we call it as heart failure with preserved ejection fraction, which we'll talk about. So the average age of generally patients presenting more commonly with acute decompensation is 70 years, and of which the epidemiologically it is shown that 61% of acute decompensated heart failure presents in males, and 37% of these patients will have new onset ADHF. So otherwise, previously patients who have not had any cardiac problems, they present with a new onset ADHF in 37%. And out of this, 42% of them are found to be due to acute coronary syndrome. So this is the epidemiological data that we have across the globe. And when you talk about clinical features, 65% are known to present with acute decompensated heart failure, of which 16% present with pulmonary edema, and hypertension with acute decompensated heart failure occurs in 11%, 4% present with cardiogenic shock, and 3% present with right heart failure. So this is from the large epidemiological data. These are the sort of stats that we have with regards to ADHF. And as I already mentioned, 30% of the patient are symptomatic with either shortness of breath or dyspnea. And PND, paroxysmal nocturnal dyspnea and fatigue tends to occur as symptomology. And patients will have exertional dyspnea, and after exertion, they would have prolonged sort of a periods for recovery to happen, which is a very hallmark of acute decompensated heart failure. And they can present with nocturnal cough or wheeze or with paroxysmal nocturnal dyspnea. So any of these symptoms can be present as clinical features of acute decompensation. So typically the patients present with fatigue and dyspnea and sort of exertional dyspnea, and their recovery after exertion takes much longer time. Some of them can present with nocturnal cough and wheeze also. So these are the myriad of symptoms that people can present with. And when you talk about clinical signs when they come to hospital, pictorially it is represented here to make it easy that they would very often in ICU when they come with heart failure, we seldom try to appreciate the raised JVP. So I tell all my trainees, please look into JVP. Very often that is a good giveaway. JVP is elevated. It's a very good marker to suggest that patient has possibly heart failure. So raised JVP, don't undermine looking at raised JVP in ICU. And specificity is shown to be 93%. So which has a very good specificity. When it is high, that the likelihood of them having heart failure, decompensated heart failure is very good. But sensitivity is a bit low. It's shown to be 57%. So they can present with pleural effusion. And if you auscultate the lungs, so they would have crackles and wheeze. But increasingly in ICU, we tend to do ultrasound. But don't undermine the value of clinical examination. So any new onset wheeze in an elderly patient, I said don't label them as bronchial asthma or COPD. To all my trainees, I tell acute wheeze in a non-COPD asthma patient is a misnomer, which means you have to look for heart failure because the pulmonary edema itself will be manifesting as wheeze and crackles. So please remember this: acute onset, new onset wheeze is not COPD or asthma. It has to do with something with heart failure. Remember that in ICU because increasingly we see patients coming and presenting with wheeze. And very often they say patient has not had a history of COPD and asthma, then it means you have to look for heart failure. And carefully, if you look at heart, they would have a gallop, they would have a third heart sound. And if you pick up a murmur, then there may be underlying valvular disease, which may be the cause for heart failure. And if there is right heart failure or congestive cardiac failure, there can be hepatomegaly. And ascites can be present in acute decompensated heart failure and pedal edema. So these are the constellation of symptoms that any of intensive care doctor has to look for, and you could easily pick up. Raised JP is something that I always look for during in rounds, and crackles is always something you go and listen to the back, you do hear crackles. And pedal edema, always look into lower limbs in ICU. You would see if there is pedal edema, it is a giveaway. And ascites, obviously, if it is picked up in ultrasound, you can make sense of it and help you in diagnosis. So this is just pictorial representation of all the clinical signs that you can look at in ICU. And this is important. So heart failure, gone are the days where heart failure means it has to have low ejection fraction. Increasingly, we are seeing heart failures coming to ICU with preserved ejection fraction, where your systolic function is normal, but they would have heart failure symptoms. So that is something we are increasingly seeing. So this is a new thing that is introduced, heart failure with mid-range ejection fraction, where if your ejection fraction is 41 to 50% and they present with heart failure symptoms. And heart failure with reduced ejection fraction, you don't need much of clinical acumen to recognize this because systolic dysfunction with ejection fraction less than 40%, it is easy for you to sort of attribute the symptoms to heart failure. So these are the three categories of heart failure. And acute decompensated heart failure, symptomologically, they are divided into presenting with no pulmonary edema. The second category is coming with pulmonary edema. Third is who present with high output heart failure. And the fourth one is who come predominantly with right heart failure. And the fifth variant, which I showed you, 3% of the cases tend to occur with cardiogenic shock. So we see all these sort of problems. Acute decompensated heart failure with no pulmonary edema, we wouldn't see in ICU, but we see all the other four categories in intensive care. And pulmonary edema is known to occur, as I've already mentioned, in 16% of the patients with acute decompensated heart failure. And out of which severe pulmonary edema tends to occur in less than 3% of the patients. So in ICU, predominantly we see this 16% of the patients who come with decompensation and present with shortness of breath, and invariably we see high filling pressures and pulmonary edema in these patients. So patients presenting with severe pulmonary edema, which happens in less than 3%, invariably it is shown that they present with a high systolic blood pressure of more than 180 millimeter mercury. And these are the patients where you do a chest X-ray, you'll see a so reverse bat wing sign and hilar shadows and lot of alveolar opacities, which typically suggest to you that they have pulmonary edema. So now, after having understood the epidemiology and the types of heart failure, so as the intensive care doctors, we need to be clear about what are the etiologies for acute decompensated heart failure and what are the precipitating factors. So very nicely, you can divide into coronary problem, valvular problem, myocardial problem, and you have a arrhythmia problem. So these are the four categories which are the etiology. So when you look at coronary, acute coronary syndrome is the most commonest cause of someone presenting with acute decompensated heart failure, or you can have a ventricular septal defect or a rupture of the interventricular septum, which can lead to heart failure symptoms. And arrhythmias are very common in ICU. We do very often see patients in the ward, they would have gone into AF with a fast ventricular rate and they come with heart failure symptoms. So atrial fibrillation is a very common cause of worsening heart failure or heart failure symptoms in ICU, or someone with any arrhythmia, atrial flutter, or when it can be ventricular tachycardia, ventricular fibrillation, or high frequency ventricular ectopics, or any arrhythmias can push someone into decompensation and present with heart failure symptoms in ICU. And myocardial patients, someone with a viral infection who has severe myocarditis, they can present with myocardial dysfunction and heart failure symptoms. Valvular, very important. When you do echocardiogram, try to look for any valvular conditions. If they have a big regurgitant jet at the mitral valve with the mitral regurgitation, or mitral tear and mitral perforation, or someone who has aortic regurgitation, or progression of ventricular septal defect, all these can lead to heart failure symptoms. So very easy to categorize acute coronary syndromes, myocardial problem, and arrhythmias, valvular problem, and cardiomyopathies. So cardiomyopathies also are very common. Elderly patients, they can present with hypertrophic cardiomyopathy, which leads to increased filling pressure, or they can present with restrictive cardiomyopathy. So these are vectorial representation of restrictive cardiomyopathy or dilated cardiomyopathy. Or in ICU, we see very often stress cardiomyopathy or Takotsubo cardiomyopathy. Any of these cardiomyopathies can cause acute decompensation of heart failure. And very commonly in young patients, when we see with heart failure symptoms, we see someone with accelerated hypertension presenting with heart failure. So these are some of the typical etiological and precipitating factors which any intensivist would see in the regular practice, that any of these sort of situations come. But in ICU, very often what we tend to see is accelerated hypertension in younger patients. We see stress cardiomyopathy. Dilated cardiomyopathy predominantly goes under cardiologists under them. And we would see arrhythmias as a common cause in intensive care. So it's good to remember dividing them into these categories. So how do we evaluate with diagnostic evaluation? So when you have to diagnose these patients, you have to take history, whether they have had history of these symptoms with increased easy fatigability, or have PND symptoms, or patients who have exercise intolerance. All these are very important, along with your clinical examination, and evaluate what are the risk factors and comorbidities the patient may have. So obviously diagnostic evaluation includes ECG and radiography. It can be CT scan, or it can be chest X-ray, which will show you features of pulmonary edema. Most importantly, in echo, so in this talk, I would stress on what we do in our practice. Typically, we do echo evaluation, and I'll focus on assessing the diastolic function and looking at the B lines as very important tools to confirm the diagnosis of decompensated heart failure. And we can do NT-proBNP. So these are the constellation of investigations and clinical evaluations we tend to do to determine and establish the diagnosis of acute decompensated heart failure. So when you do ECG, typically in acute decompensated heart failure, they can have a very tachycardia issue, or they can have atrial fibrillation, or you could see whether they have any ST elevation MI, or there can be LVH pattern with a diffuse STT depression. So any of these patterns will at least tell you that there is some underlying cardiac problem, which is possibly the cause of acute decompensated heart failure. And when you have to diagnose, you can divide the ADHF into 4 categories. The commonest, warm and dry, as the name suggests, that patient is heart function is good and there is no edema. And warm and wet is where there is a lot of edema, pedal edema or ascites. Cold and wet is intuitively, it should tell you that patient has a low cardiac output and they have a lot of edema. And cold and dry. So the commonest one we see is warm and wet, where patient has edema and cardiac function can be normal. And this warm and wet, which is the commonest one of ADHF, occurs in more than 70% of older adults, more common in females, and they present with pulmonary edema. The degree of pedal edema is usually little less. They will have more of pulmonary edema features. The cold and wet, where your cardiac output is low and where they have edema, it occurs in less than 20% of the patients. And these are the patients which typically present with low cardiac output or cardiogenic shock, which tends to get admitted in CCU under cardiologists. And the cold and wet is the most severest of the ADHF because they have increased risk of death. And they are the patients who have to be worked up for cardiac transplant, and they tend to need cardiac transplant within a year of diagnosis of this low cardiac output, is what has been referenced in the literature. So these are warm and dry is rare, tends to occur in less than 10% of the patients. So these are just the categorization of ADHF that one has done. So I'll just focus a bit on what we do in ICU when someone comes with ADHS. Looking for B lines on ultrasound is very important. So as you see, the typical B lines are hyperechoic, and when you do a lung ultrasound, there won't be A pattern, so there will be arrangement of the A lines and there will be more of B lines. So what is interesting to note is if you have B lines which are separated by 7 millimeter, it is suggestive of more interstitial edema. If it is less than 3 millimeter, it means if they're more densely present, then it means there is more of alveolar edema, and the B lines tends to extend to the bottom. And why does the B line happens? But generally because there is edema in the interlobar septa, and the sonology waves tend to reverberate and gets entrapped in this interlobar septa, which is seen as B line. So that is the conceptual understanding as to why B line occurs. So the edema present in all the interlobar septa are identified or entrapped by the reverberations of the sonological waves, which is seen as a B line. And just to show, so this is a interstitial edema, you can see, which we have done in our ICU, where they are separated by 7 millimeter. And this, if you see, these are alveolar edema, where you have a very densely present B line. So both of these are from our own ICU, where you see the left one is an interstitial edema separated by 7 millimeter. The right one is alveolar edema, which is more densely packed. So the B line uses 1 to 2 B lines are normal, which can be present in 28%. More than or equal to 3 are pathological. So the differential diagnosis of B line, as I said, is CCF. It can be present even in ARDS or ILD. If there is no A or B line, then one has to think whether there is consolidation or pleural effusion. So as you see in consolidation, you will have this shred sign where you have hepatized lung or a tissue sign that you would see. So this is just to debrief about the importance of B lines. And in ICU, I'm sure many of you would be already doing, we follow something called blue protocol, where if you have a lung sliding present, you look for lung sliding as a first step, whether you see whether it is present or absent. If it is present, you have to see whether it's a B profile. If it is B profile, it is simple, it is pulmonary edema. If it is A profile, then, and patient is hypoxemic, you have to look for any clots. You have to do a lower limb Doppler and look for any presence of venous thromboembolism. If that is present, think of PE as a cause of hypoxemia. So if the veins are patent, then you have to do a PLAPS. So then you look at the PLAPS and then see whether they have any pneumonia or consolidation. If there is no PLAPS, then the cause for hypoxemia is COPD or asthma. So I'm just trying to revisit how we approach the blue protocol. If lungs sliding is absent, then look for B sort of a profile, B predominant profile. If that is present, then possibly patient has consolidation or pneumonia. If it is A predominant profile, then you have to look for any sign of pneumothorax or look at alternate diagnosis. That is the sort of a overview of blue protocol that we tend to do. But what is important is lung sliding, and if B profile is present, simplistically you can say that patient has pulmonary edema. And Doppler measurements is something we do routinely in our ICU. So you look for mitral outflow, where you look for E by A and deceleration time and intraventricular relaxation time. Then we look for pulmonary venous inflow pattern. So what we typically do in ICU is we look for filling pressure by doing E by E prime, by placing the Doppler at the mitral annulus, and we look at the filling pressure. So the E velocity, I'm sure many of you would be doing, you would place the cursor at the mitral valve movement, and then you put the Doppler wave, and you look, the first wave that occurs is the E wave, and the second wave you see is the A wave. And then you look at the E and A, and the ultrasound will give you the E by A ratio. And you look at the deceleration time of the E wave that is present, and that is normal is 160 to 240 seconds. And the E by E prime, when you look at the grading of diastolic function, so this is the measurement. You place the sample at the annulus of the mitral valve, and you put a Doppler, and you'll get the E prime. You measure it by keeping the Doppler measurement at the first wave, which gives you the filling pressure. So when you do the grading of diastolic dysfunction, so the grade 1 is very simple. E by A will be less than 1, or deceleration time will be more than 240 milliseconds, and E by E prime should be less than, which means the filling pressure is normal. So when we do diastolic function, you measure the left atrial pressure, and you look at whether there is reduction in the compliance or increase in the diastolic filling pressure. Grade 1A is where you have E by A less than 1, but your filling pressure is more than 15. Grade 2 is very simple. E by A is 1 to 2. Deceleration time is 160 to 240 milliseconds, and filling pressure is more than 15. And grade 3 is E by A is more than 2. Deceleration time is less than 160, and E by E prime. So once you cross grade 1A, then you see most important tool for you to fixate whether there is decompensation is to look at filling pressure, which is got by your tissue Doppler by placing the sample at the annulus of the mitral valve, which will give you E by E prime. So for diagnosis of acute decompensated heart failure, your filling pressure becomes more important. From grade 1A, you will start calling as decompensation or high filling pressure, and there is a heart failure symptoms. So that's about that. So I've only focused on ECG as the tool, and most importantly, the lung ultrasound looking for the B profile and the Doppler measurement to ascertain the presence of decompensation heart failure. But systolic dysfunction is something very intuitive. If they have low ejection fraction, obviously you have ways to measure that. And in ICU, we do E-point septal separation. If low ejection fraction with a shortness of breath, obviously you'll call it as acute decompensated heart failure. So when you talk about management, the most important aspect is this patient should be connected to the monitor, and all the vitals, the heart rate, saturation, blood pressure, respiratory rate has to be monitored in a monitor. It can be ICU, CCU, or any place. So monitoring becomes important, and patient has to be immediately put on non-rebreathing mask or oxygen because of hypoxemia. And they have to be two secured, two IV cannulas has to be secured for doing all the blood tests and administering drugs. And once there is a diagnosis of acute decompensated heart failure, NIV has to be thought of to reduce the work of breathing, because there's umpteen number of studies which have shown CPAP shown to improve the outcomes in patients with acute pulmonary edema due to decompensated heart failure. So they have to be given trials of non-invasive ventilation, and diuretics has to be given. So furosemide 40 mg IV stat or higher dose may have to be given in patients who have a recurrent sort of a heart failure symptoms. Whilst you are resuscitating this patient by putting them on a monitor, connecting them to an oxygen, so one has to look for etiology, whether patient has coronary syndrome, whether patient has a arrhythmia which has to be addressed, or accelerated blood pressure which needs to be controlled with antihypertensives, or patient has valvular. So whilst you are stabilizing the patient, please look for the reason, whether they have coronary syndrome, arrhythmias, or accelerated hypertension, or valvular problem, or cardiomyopathy of some sort, and treat the underlying cause whilst you are doing that. So I'm management, I'm just going to give you a broad overview. So if there is an accelerated hypertension or if there is a regurgitant lesions like MR and AR, so your focus has to be to reduce the afterload, and you can use vasodilators for that. Sodium nitroprusside is something that you could consider in accelerated hypertension to reduce the afterload at the dose of 5 to 10 micrograms per minute, and all this has to be titrated to the effect, and maximum you can go up to 400 micrograms per minute. If there is a lung congestion with pulmonary edema, then your whole effort should be to reduce preload. For reducing preload, please use along with diuretics, you have to use NTG, nitroglycerin at 5 to 10 micrograms per minute, and titrate every 3 to 5 minutes, and you can go up to 200 micrograms per minute. If it is a known systolic heart failure, where your systolic dysfunction is present, then you could do arterial vasodilatation along with NTG by using dobutamine, which has an inotropic effect and vasodilatory effect. And one has to think of intra-aortic balloon pump also in this situation if patient is refractory to dobutamine and NTG and diuretics. So the whole tenets of heart failure management is preload optimization, afterload optimization, and improving the contractility. If there is a known diastolic heart failures, which we increasingly see, then one has to consider using beta blockers to reduce the heart rate. And if blood pressure is an issue, you may have to use vasopressors. But in case of known diastolic heart failure, one has to avoid usage of vasodilators like nitroprusside or inotropes. So this is something you have to avoid when there is a known diastolic heart failure. So just to summarize, so what we have learned in this whole thing is just spoke about definition, which means patient should be symptomatic with increased filling pressure with sort of a systemic edema. And acute decompensated heart failure can be divided into these four categories: without pulmonary edema, with pulmonary edema, high output heart failure, or right heart failure, or with cardiogenic shock. I have not spoken a lot on right heart failure, just given you a brief overview. And clinical signs, please in ICU look for JVP, look for pleural effusion, look for pedal edema, and look for crackles and wheeze. And diagnostic evaluation is taking into cognizance the history, clinical evaluation, and evaluation of risk factors and comorbidities. And it is a multimodal way of diagnosis. Look at the ECG, look at the radiological imaging, and look at the echo findings, and look at lung ultrasound, look for B lines, and NT-proBNP will help you confirm the diagnosis and have some clarity on the broad principles of management, which I showed you in an algorithmic way, is a way to go about. So that's about it. It's a broad topic. I tried to cover the salient aspects which are more pertinent to intensive care. So I request you all to submit your valuable work to Journal of Acute Care, which comes out every 3 to 4 months, and can visit my website to rehear to this lecture. Thank you. Thank you, Nando.